there. Okay, so we are beginning. What I'm doing today is more or less a review, I've made the same kind of an apology for, maybe that's not the appropriate term to use. Is it has been a difficult period of time. We had my mother-in-law's funeral. I reached 98 and a half years old yesterday, but it's been ongoing for a couple of years and it's really had redlined, coincidental with the start of this term and coincident and the end of last term. And all the wedding activity, everything sort of, I sense that it has distracted me and distracted maybe the way I've been able to do classes. Hopefully I'll be back on the page. We'll get everything in, but I just felt that, and if you're wondering, and I was generally very pleased. I know we had some trouble deploying the test. I do have everything graded more or less with a couple of exceptions. I had some difficulty getting them on because we had some problems with our photocopier this morning. So surely they will be posted tomorrow latest at some juncture. But in general, people did, and it was by intent to make it easier for you, because you can imagine when an exam like that, and I felt, because I was doing it hurriedly, without having the time to review it. If I had done that closed book, I think you can imagine just looking at the test, it might have impacted the grades adversely. And I was trying to give everybody a chance to get off with a good grade, because this stuff only gets harder, not easier. I'm being very honest with you. So I wanted to give everybody an opportunity. It was by intent. I did it with my micro class. I didn't have to do it with my advanced physiology class. It's different. They're mostly pre-med students who are trying to get into medical school. It's a little different bar. You're early in their career. They're at the culmination of theirs. So without that, I've used the other PowerPoint. I loaded this on your Blackboard. This is the Marie PowerPoint, plus I have a very good outline that covers all this stuff. So if you don't want to listen to me, I don't blame you. Okay. Most of it's covered. All right. Today, I'm going to try to get as close to the clotting as I can. I'm going to spend tomorrow doing the clotting stuff and probably get into blood typing and conclude this particular unit that's there. Unfortunately, I have a great deal of information about this for my own health reasons. Okay, and I will get into that very shortly. So this is just amplifying some points I made. What they didn't have in the Welsh Whole textbook, they didn't talk a lot about this. I mean, there's 3 proteins that are dissolved, and I wrote this down. Typically, we have about 8 grams. We call it grams percent. If you don't remember what that is, you should become familiar with it career-wise. It means there's 8 grams of total proteins in your blood for every 100 milliliters. It's a percentage, a concentration. When you talk about blood sugar, which we just did with diabetes, let's say your blood sugar is 110, that's milligrams percent. It's the old story like when you were in grade school, apples and oranges. You have to know whether it's grams or milligrams. I think that's very important. Because that's the kind of stuff they trip you up with on tests, RE nursing, clinical tests, stuff like that. So I'm not having you recall all those numbers and things along those lines. But these are made by the liver. So people with liver disease, with hepatitis, cirrhosis, awaiting liver transplants, they don't make enough of these proteins. Look at what they do. This albumin it acts as a buffer because it can absorb either protons or donate protons. That's what buffers do. It's not as good as the carbonic acid buffer, which we're going to spend a lot of time talking about when we do the blood pressure unit and we do the kidney unit. Okay. And because it has both fat soluble and water soluble elements, it can latch onto things that don't dissolve in the bloodstream and allow them to dissolve. So they're carrier molecules, and other proteins do that as well. But most importantly, they contribute to something called osmotic pressure. Your blood, in the absence of protein, if you've ever seen somebody with liver disease, awaiting a transplant, or better yet, a malnourished kid in some war-torn area, okay, they have spindly arms and legs, and they have big, big bellies. It's not fat, that's fluid. That fluid has come out of their bloodstream because there's nothing to hold it in. The protein holds it in. What we do, when aid comes to those places, whether it's natural disasters or war, famine, whatever can be the problem, they come in with proteins, they come in with potable water, they come in with antibiotics. That's what they need. Those are the things that you need that are inevitably in short supply. So albumin, we'll talk about this a lot. It offsets your blood pressures, pushing fluid out. Because when it gets to the capillaries, there's little openings that the fluid can shoot through. The only thing that's holding it in are those that's offsetting it. It's by design. We get to the start of a capillary bed, it's designed to let stuff out. At the end of the capillary bed, it's designed to pull it back in. So it's this offset between blood pressure, we call hydrostatic pressure, pushing it out, and this onconic or osmotic pressure, holding it in. Very neat thing the body does. Hard to read. I can't do much with it in this particular instance. But I'll tell you a little bit about the albumin is the most abundant, 60%. The globulin's about 36%, not as much. And gamma, we're going to talk about an immune system because that's immunoglobulins. But these alpha and betas, they also are carrier molecules. When you hear about folks they carry fats around a lot, particularly the fats when we hear about people with cholesterol problems or fat problems in their bloodstream or excessive amounts, predisposed to heart and cardiovascular disease. They're talking about those globulins, the alphas and betas. And the one that's the least, but certainly the one that's as important as any, is called fibrinogen. You'll remember blood is a connective tissue. It's liquid. There's nothing in the books that says connective tissues have to be solid. The matrix is liquid. It has to have fibers. Fibers are dissolved. The fibers are fibrinogen. The O-gen means they're soluble. The whole ball game for clotting is to take those fibers and convert them to another form that's insoluble called fibrin. The whole goal of the clotting cascade, and there's two ways to get there. Basically, they're coming to the same point. They're going to take the fibrinogen, make it turn into fibrin. It comes out of solution, and for all the world, it forms like a giant fishnet to trap red blood cells, platelets, and other factors to make a clot. You're going to see an illustration of this when we do the clotting number. It's one of the best illustrations in the whole text to really show you what it looks like, what a clot is. It's Mother Nature's design that mimics something that we see in real life, interestingly. So the O-gen just means a precursor or an inactive form. You're going to hear that term a lot. So we call them formed elements because they're not all cells. Okay? The only ones that really, white blood cells, the only one that look like a cell. Everything else is either a fragment or it doesn't have a nucleus. So we'll move on from that. That's what it looks like. It's an actual micrograph. White blood cells always have, it looks like they're ruffled or fuzzy. Really are, there are tons of tentacle-like projections that are sampling the environment, and there, as they roll over things, they latch onto them. That's how your white blood cells work. You know, they're attracted by things, but basically they're rolling over, and when they catch something that isn't supposed to be there, they latch onto it and then march out. You don't want to get on the wrong side of a white blood cell. Blood smear, maybe in lab you'll look at that. This is the whole idea. Red cells, it's all about hemoglobin transport. They're very flexible. And a lot of what we do today to enhance blood flow is to increase the amounts of flexibility. The same thing with platelets. There's a lot of the modern anti-clotting mechanisms are designed because when these things slam together, they clot. So it has changed because a lot of the medicines we use to stop things from clotting have a fair amount of side effects. It's very difficult. I mean, your blood always has to be able to clot, and if it doesn't, it's going to have problems. So even if you have a clotting disorder, you still have to find a way so the blood clots when it's supposed to and not when it's not supposed to. Maybe that's the way to express it. So I commented on this. It's really designed for carrying oxygen. That's its job. Biconcave disc. Did all this. I talked about the heme. We recycle the iron. We recycle the globin, which are the protein or polypeptide components. The good news, and they're easy to recycle. The heme is this interesting thing that the iron attaches to that we can't recycle, so we have to dispose of it. And effectively what happens is, and you have the same illustration in the other text, That's the iron we can recycle, but this part we can't. And there's oxy and deoxy, and we'll talk a little bit about the carbon dioxide later and where they come from. Kind of covered that. But what's interesting about it, I just lost my train of thought for a second, with regard to this, is they're going to come up with a slide. So this we have to dispose of, and we dispose of it in urine and feces. Your liver basically does the job, and when it produces something called bile that helps us digest, okay, there's also some of it that's going into the, so some of it's going in, eventually be excreted out with urine, and some with feces, and it imparts the color that we are accustomed to seeing with both those waste products. Interestingly enough, and big problems when they back up. Big problems. So here you can see, so when we look at these, they start from stem cells. And the whole idea of this is we're trying, once they get into a particular way, they're going to go in that direction. The big problem, I was sharing this with the other class, we look so closely at this. And hopefully for Friday, I'll remember to hook up my own lab so you can see what the blood counts look like and what the numbers look like. And mine are okay, but I have a certain amount of anemia that's associated with it over the years. But you get so much information, and it really is important. You look particularly what they call, you're going to see it's called the differential. We look not only at the white blood cells, but what proportions there are, and are there immature forms. We look at the red cells, and we're going to look at something called the reticulocyte. It's supposed to be there. You're always, as stuff gets pushed out of your bone marrow into the bloodstream, there's going to be a certain number of forms that aren't mature. We know that. It's when there are too many immature forms or too many older forms that we have a problem. Either stuff is getting stuck in there and isn't coming out, and the cells are effectively elderly and not able to do their job, or worse yet, they're getting pushed out so rapidly. Is there something pushing them out, like a tumor? Is there a disease or an infection that we can't fight and it's getting pushed out too rapidly? And what happens, these are the ways we fight infection. And the analogy that one of a professor of mine said, it's kind of like fighting a war. And if you're putting out experienced troops, and if those troops are slain, and really that's what happens to white blood cells, they die in the fight, we keep pushing more out. If we are winning the war, that's fine. But if we're losing it, we end up with immature forms. And it's like in the battlefield. You have untrained troops, they're not going to be very successful. So we were able to actually ascertain the levels of those types of things. So it's very, very unique, and it's something maybe you'll become acquainted with as your studies move on. Many of you will, and you'll look for forms like this. This is what doctors look like when we study those tests. We look for immature forms. And it's normal early in the fight, okay, because you're pushing out a lot of troops. But later in the fight, it suggests to you, early in the fight means, we're just starting the battle. Later in the fight means we're losing. And losing is bad when it comes to infection. Let me show it to you rather than talk about it. These are the ones, they have little bits of ribosomes, little bits of endoplasmic reticulum. They are normal in our bloodstream, about 1%. That 1%, plus or minus a little bit, basically says that's, you have, even though this is an immature form, 99% or so are fine. That's perfect. When that number varies in one direction or the other, there's problems. And as you'll see, unlike most time when we think about something maturing, it gets bigger, it gets stronger. Here, maturation means getting smaller. Its whole job of a red blood cell is very, very, very easy. Carry oxygen. To do so, it accumulates hemoglobin and eventually sheds everything. It sheds its nucleus, sheds any internal hardware, endoplasmic reticulum, ribosomes. See ya. Now it's designed for that. This is the reticulocyte. We know there are going to be a certain number of them. That's the price of doing business. If 1% are like this, 99% are good to go to carry oxygen. When we start to see these things that have residual amounts or of nucleus still left, that's a big trouble. And that's the way we analyze disease. We do things called a bone marrow aspiration. We have to wonder what's in the bone marrow. Again, is something pushing out? Is there a disease? Is there a defect, etc.? It's one of the things we do in the workup for blood disorders. I mean, that's a pretty common bedside procedure in a hospital. So we don't have enough, not enough oxygen. If you have too many, it's too thick. See how many we make per second, immense amounts. Do the math every day. Think of how many seconds there are in a day and multiply that by 2 million. It gives you an idea of just the immense amount of red blood cells we have. The other thing I should have mentioned, I'll go backwards, is normally when there's not enough iron, these cells get smaller because they're filled with hemoglobin. Without the iron, you can't make the hemoglobin. Or not only are they smaller, they're paler. So we call it a microcytic anemia. Now, what I have to a certain extent is macrocytic. My cells are too large, not because large isn't better. Large means they're maturing inappropriately. I have a certain lack of B12 that I have to compensate for with vitamins, though it's improved. There's another one from folic acid. So most people get enough folic acid in their diet. So my advice to you, take a multivite. Would it hurt you? Do it now. I mean, it's up to you. If you had a balanced diet, you're going to get all that stuff. But there's a zillion great vitamin supplements for whatever you like that are there. They're constantly. The supplement industry is not under the auspices of the FDA. Be aware of that. Not all supplements are created equal. Look at the testing information. It goes along with it. So you got to be a little careful with that. It's not like it's at the pharmacy or it's right there on the shelf. This must be safe. That whole assume thing, the problems with that. So we talked about erythropoietin in the endocrine unit. Basically, they're for hypoxia. Okay, and so we increase the amount of two most common areas where we see it being utilized: altitude. Because it takes you about 2 weeks to maybe as much as 2 months if you move out to Denver or Salt Lake City or go to Mexico City. Okay, it takes you that long to adapt, as opposed to, and it happened to me when we went out to visit. At the time, my stepdaughter was living in Denver. It was like, oh my God, did I get, got off the plane, and the next day I'm like, oh, headache. I mean, it was a mess for like 24 to 36 hours. Nobody else was, but I probably the least healthy of everybody who was there. And then what we see here why we see people whose blood is a problem actually is getting thicker, because that's what happens. Up at altitude, more erythropoietin to compensate for the lack of oxygen. Not so much it's tragic, but problematic. Here, it's people who have respiratory problems. Anybody with emphysema or obstructive pulmonary disease. All those folks you see tragically walk around with those oxygen bottles. Ain't good. Typically what's happening is they're constantly getting a signal to make their blood thicker because they're not getting enough oxygen. The trouble with that, and why it's a vicious cycle, all the heart knows is, I need more oxygen. I'm going to pump harder. Okay? And at the same time, your blood's getting thicker because your lungs aren't going to get dramatically better right away. And eventually something's going to give, and usually it's the heart that gives. Pump harder, work harder, blood gets thicker, work harder still, blood gets thicker still, etc. And eventually the system fails. That's what we call heart failure. And there's different, this is why men typically it's a little bit higher red count than women. I talked about that when I did the presentation previously. This is using it inappropriately. Years ago, they used to use erythropoietin. Now they do blood doping. They spin the blood down. They siphon off the fluid. They siphon off the plasma. They siphon off, little bits of that buffy coat. And basically, we have what's called pack cells. And so they're giving themselves auto transfusion. You're transfusing in your own blood. And cycling is the worst culprit, just by far. I love watching the Tour de France, but they're the worst culprit. risk, more so than that. And so I mean, every so often you'll hear about somebody who succumbs during that. Iron, a little bit different. The trouble with iron is sometimes we have to bind these. And there are some diseases that are associated with this, which are problematic with iron and iron storage diseases. When we store those iron, I mean, you might have seen somebody, you know, somebody who's older and has had a really bad bruise or a blood clot, or maybe they have really bad varicose veins that have leaked. What you begin to see is it's almost like a brown appearance of their leg. That's from a deposition of what's called hemosiderin. And the worst part about it is it itches. Iron under the skin, and you'll see them. Usually we'll deal with elderly patients. I have a lot of experience with this. They're sitting there. In the nursing homes, they have to trim their nails. Okay, so they can't because they're going to scratch. I mean, in the middle of the night, they're scratching. They're taking the other foot and they're scratching with it. The skin breaks down. It gets infected. It's called a stasis ulceration. And I wrote papers on this. I treated patients with like this for 25 years. So there's a whole lot to it. And so we're very cognizant about this. Being the liver and the spleen does most of it, even in the absence of a spleen. If you had lost a spleen due to injury or infection or some type of medical diagnosis, the liver can take over. Here's this pigment bilirubin that plays a role in both the urine and the feces that we have to get rid of. And you have to know that. You have to go through that if you want to. You're welcome to do that. And so anything that causes an insufficient amount, when we say anemia, the implication is red cells. Polycythemia, poly-cy, many cell. Emia means bloodstream. A means without. So we use the term colloquially. But polycythemia, I mean, other than being at altitude or respiratory problems or blood doping, is comparatively rare. There are some cancers that cause this to occur. It's called polycythemia vera. V-E-R-A means, you know, vera, from the word from verdad in the Spanish for truth. Getting better at my Spanish this week. I got the numbers down to a science. And other terms like, you know, margarita, and it's very good with those. Just Spanish words we use a lot. Not as much as my daughter's group. So all of these things, and I make this, I commented before, and that's why I wanted to save this and talk about it. Teeth. When you don't have oxygen carrying capability, and the more severe it is, the less you physically can do without stopping. You just don't have the oxygen to generate enough ATP. You have to stop. Mine was so low from chronic blood loss and 2 major ulcer surgeries. I was walking around with a hemoglobin of 5. The normal is 15. Those steps. This is what happened to me when I was teaching at a small school. We had steps like that. Imagine how hard it is to walk like this. I could clear 3 of those steps next time. Literally stop for not just a second or two, maybe a minute. Take the other 3. That's how severely bad. Not lying. I couldn't do like I do now and race around. You know, who's this old guy running around like a crazy person? Okay, no. I was that person who looked at not even 50 years old. If I parked my car in the parking lot up by the Giant Eagle, heaven forbid you had to wait for me to cross. I would have to walk like that. I'd find a shopping cart so I had something to hold on to. And people would honk and think, why couldn't do it? Why is this guy doing that? That's how bad it is. I'm not trying to be, I'm telling you very honestly. I mean, I was, my daughter to this day will recount the story when I was so ill that she literally threw herself on my hospital and said, Dad, you're not going to be able to get me away at my wedding. Okay. I did have to wait another 25 years. We would have been a little more efficient, but hey, we finally got there. I didn't want to give her away. I was waiting for an offer. Where's the dowry? You know, that's the reverse dowry. Okay. Let's talk turkey. You want to marry her? Money talks. I don't give her away. Where was it carved in stone that you couldn't negotiate? You want to make me an offer I can't refuse. No, sorry. I told the other group, I'm a Godfather devotee from the movies and all the stuff, and wonderful series, and all the YouTube, all the stuff about it. So she got me it's almost like with the Godfather logo, except the T-shirt said Bridefather. It's my daughter's wedding day. Anybody asked me her favor, I couldn't refuse. Not being Sicilian, it didn't necessarily apply to me, but I can imagine. But fatigue, difficulty breathing. And there's so many reasons behind it. So it can become from blood loss. For me, it was chronic blood loss. This is what happens acutely. It's life-threatening. For someone like me, it was chronic blood loss from a bleeding ulcer. And the trouble was that it doesn't matter. They were pumping. I had maybe 50 units of other people's blood. I've had a lot of transfusions. Talk about that in the blood. But this is all 1998 to 2000. So it's a quarter of a century already. And I'm still here to tell a tale, fortunately. So all of these are kind of offshoots of iron deficiency anemia. And again, there's little cells. They're small and pale. We call it microcytic. Iron is one way to treat it, but you really have to go to the underlying cause more than anything else. This is what I have a little bit of now because I probably am not getting enough B12. You can, typically what happens, your stomach makes the intrinsic factor. I'm probably not making quite enough. But you can get this in with injections, nasal gels, things like that. There's ways to supplement it. One of the problems, if you did not know, for people, not so much for vegetarians, for vegans, most B12 in vitamins and things like that, if you are indeed a vegan, come from animal sources. You can go on Amazon and just pay more and buy vegan-friendly B12. It's not a problem. It's just costly. If you did not know, or if you're a vegan, or you probably do know, but if somebody in your orbit who is, or like me, when I cook for a lot of vegans, it's expensive to get stuff that really is vegan. Some people say it is, it's not. And we already talked about one of the things that people have when their kidneys go bad, they can't make the erythropoietin. Aplastic anemia is a little bit different. Most of the time I have seen it's been associated, obviously, with radiation or chemotherapy, but there's certain antibiotics and certain other medications that have had this a bad side effect that are there, and you really have to do something. Now we have bone marrow transplantation, which has really been literally a lifesaver for a lot of individuals, fortunately. So these are, and I'll comment on them a little bit more. Sickle cell you're probably already familiar with, because if you just go back and listen to what I had to say. These thalassemias are genetically based. They involve clotting factors, interestingly. The classic anemia that we're going to talk about, the classic clotting deficiency, is called when we talk about hemophilia, bleeding disorders. Thalassemias kind of overlap that a little bit to a certain extent. So we look for certain factors that are involved. It's a very interesting topic. We see that in people of Mediterranean descent. The name for thalassemias are familial Mediterranean anemias. So they're unusual in and of themselves, I would say. They're not. They're more. I think they're more common than sickle cell. Not all of them are as severe as some of the others that are there. Here's the Mediterranean. There's certain inherent deficiency, and they can be extraordinarily bad or extraordinarily mild. Just be a diet. And a lot of times, we worry about these kinds of things when someone's having an operation. Do we have to do something to augment their ability to heal? I'm going to skip over this. You're going to see it. If you did not know, folks with malaria typically are not susceptible to sickle cell. It's sort of an offshoot because malaria, basically the invading parasite basically targets hemoglobin. It doesn't like sickle cell hemoglobin. It's interesting. And now we have more ways to treat it than we used to. That's a classic sickling of the cell, or micrograph that you see. Here's the one when there's too many, polycythemia vera. It's almost always cancer oriented. There's ways that you basically have to remove the blood on a very, very frequent basis. And the secondary ones we see much more commonly. Athletes utilize this as well. The white blood cells, you have to understand that's really important. And this is really where we look at some of those blood tests to make sure we're not having big problems. So you're looking at, you want the numbers to be there. There's about 1,000 times more red cells than there are white cells. But we look at the white cells because this is the way your defense is. And this, you need to remember this. It's one of the few mnemonics that's easy and works. Because you've got to know the proportionality. Neutrophils, lymphocytes, monocytes, eosinophils, and basophils. We go over this again and we go over it again when we look at the immune system. The neutrophils are the most abundant. They're the first ones on the scene when there's damage or infection. And more importantly, on top of that, they're your bacteria slayers. So when we see an elevated amount of neutrophils, most likely it's a bacterial infection. Lymphocytes are maybe 20 to 40%, 25 to 45%. So there's a fair range that encompasses normal. They're there for viral infections. If you're dealing with somebody who has a flu, okay, and we happen to do that, you're going to see an increase proportionally of lymphocytes. There'll be less neutrophils, more lymphocytes. And again, how well are we fighting it? We look to see if there's immature forms. Are we early in the fight or are we later in the fight? There's all sorts of ways to assess this in the laboratory. So really, there's a lot of sophistication in the science. And then monocytes, and then eosinophils and basophils that are there. So, I mean, you can see that every textbook, every lab will have different percentages that are there. The only ones that really change are the monocytes become macrophages and the basophils become something called mast cells. They are significant with regard to allergic diseases. They're significant with regard to asthma, and they're very significant with regard to the life-threatening condition called anaphylactic shock. We'll explore those when we get into immune system. That's one of the things for any of you folks who are going into clinical things where you're going to be injecting people or administering medicine intravenous, because it's more common that way. You have to be in the back of your mind, if I give them this shot, you have to be mentally ready to respond to potentially them going into an anaphylactic shock crisis. You just have to be. I'm sorry, it's none of us are. You're allowed to have you're allowed to have a second or two of, oh my God, like that. But after that, I mean, there's a very useful word that we utilize in these instances. Help! Is that word? And you have to know how to respond. That's why they have epinephrine on a crash cart. They're going to have an EpiPen. You're going to be able to zap. Anybody can use an EpiPen. Take off the lid, boom, put it in. I used to give myself a shot like that. It's a subcutaneous. It's crazy. I mean, I saw one of my stepsons they have a farm. I mean, he's allergic to bees. That kind of allergy doesn't carry an EpiPen. Go figure. You know, some people are just stubborn. Nevertheless, here you can see all of these. This is the basophil, and eventually when it leaves the bloodstream, it forms this interesting thing you'll see called a mast cell. These are the eosinophils because they're red staining, etc. And we go over this, and I did quite a presentation about it that was there. This is very interesting, some of the things that they're able to do. How do they fight bacteria? I mean, sometimes they will act, not only are they there, they will directly attack them. Imagine this. They'll shoot little granules at them, okay? And what those granules do, they will perforate, and then they'll shoot chemicals into the perforation. That's pretty clever. Secrete something that'll punch holes in the outer border of the invader, and then shoot chemicals in to destroy it, as well as gobbling it up. So to some extent, they're all phagocytic. This is pretty clever for your defensive system. That's the respiratory burst. They kill microbes. They make those potent toxic forms of oxygen we have talked about a couple of times. Okay, effectively things like hydrogen peroxide or bleach-like substances. Poke holes with them and shove that stuff in, and basically, hey, I like that. Very efficient means, and that these are these we call them polymorphonuclear leukocytes. Basically, it's one nucleus, but it's just folded, and it gives the illusion of having segments. We used to think there were many nuclei. There's one. Again, balloon puppets. It's a balloon puppet. Somebody's dad or mom in here made balloon puppets at one of their. They blew it up. It just right. You had some clown come in and do that. I'm sure. That very pretty daughter, I had to do that for her. Get the thing with all the helium, inhale the helium. So you can talk like this. You had dads who were crazy like that. I'm a card-carrying member of the Crazy Dad Society. These attack, they talk about worms, but they attack any. In malaria, you would find these elevated with the eosinophils. The basophils, again, we're going to revisit them because of their role with heparin and histamine granules. And then the monocyte forms, they don't have granules that we can see. There are granules in there, they just don't stain. So they erroneously call them agranulocytes. It's a lot of things were, before we understood it on a microscopic basis, that we had them. Basically, when you see a lymphocyte, they're either a T cell or a B cell, looking like that in the bloodstream. And the monocytes are the largest by far, phagocytic in nature. They become macrophages. They are just critical part of our immunological. They usually have this big, you can see they're twice as large as a red cell. And they usually have that sort of U-shaped or kidney-shaped kind of indentation that you see. We would cover this in immune system, all the different, basically, factors. You don't have to know them. I talk them generically when we do the immune system. And these are those immature forms. I saw they're called band cells. When you see those, that's bad in a white blood cell. I don't do the cell line thing with it, etc. Again, we look for, if excessive amounts, can be leukemias. Acute are much harder, much more difficult. They all have to be treated, but acute are much worse than chronic, typically in younger people. Mononucleosis, I just started to talk about in my micro class, is a viral disorder. It's something that's effectively, it's typically from a herpes virus and it's called the Epstein-Barr virus that does that. And then ones where when it's very low, yes, it can be responses of medication or anti-cancer drugs. Then you still have to do a workup to see if you maybe have underlying HIV heading toward AIDS, because eventually it's going to damage that immune system significantly. So I think that's something that's worth knowing about. You can read through this. Here's this Epstein-Barr. I mean, it's very common in the age that most of you are at. You're going to know somebody who has it. My ex had it when she was, I think, either in high school or when she started nursing school right after high school. Okay, she went to CCAC's program ages ago. And I mean, once you have it, you have it. You're going to find that out. It's another one of those things. It's a herpes virus, doesn't go away. And when you get it as a kid, you can tolerate. As an adult, it is no fun. Real interesting thing about a lot of viral disorders, like adults who get mumps, adults who would get chicken pox. Oh, that's not easy to tolerate. I'll give you this rest of the story. She had this. She developed adult mononucleosis after having it as a kid. We had a lot of difficult things that were going on simultaneously. It came back and bit her. My kids were 4, 3, and like 1.5. I had to hire her. I started work during the day. I had to hire somebody to stay with her. The most that she could do was in bed was to crawl, literally just with assistance, go to the bathroom and get back in bed for about 6 weeks. That's what adult mono was like. That kind of severe. Nothing you can do, just tincture of time. I was fortunate I did not have it. And really, the last part we're going to talk about is platelets. You're going to see there's a lot of thing in them. Platelet-derived growth factor, something we use in wound healing, very significant. This is where I stopped the other class, so I'm going to stop it here for you. and then we're going to talk about the clotting cascade. So thank you very much. It should be enough. We'll get done without me blabbing too much longer. I shared a lot of information. So I always like to stop at the same place. Thank you.